So good afternoon, everyone. My name is Ariel Santos. I'm the TTUHC Telemedicine Director and PI for TexLa TRC. We are fortunate today to have the pillars of the Center of Telehealth at University of Mississippi. For everyone who is unaware, University of Mississippi, together with MUSC, is one of the Center of Excellence in Telemedicine in the country. So we're very fortunate to have the CTO, or the Chief Telehealth Officer, Dr. Chandra, who will be joining us in a minute, and Greg Hall, the Director of Information Technology. Joining us here with me at the ECHO office is Will Rodriguez, Executive Director of the Correctional Management and the President of Student Interest Group for Telemedicine, Roald Credo, as well as our director here, Laura Rovald, and Max, our IT in charge here in Project ECHO. So without further ado, I will pass the baton to Roald Credo.
Thank you, Dr. Santos. This educational activity is a project of TexLa Telehealth Resource Center, a federally funded program with F. Mary Hall Rural and Community Health at TTUHC, as well as Well Ahead, Louisiana, with generous support from Health Resources and Services Administration, or HRSA. And these are some helpful tips for a webinar. Make sure all microphones are muted. Also, kindly type in your name and email in the chat box, as well as any questions and comments. Make sure you fill out the session evaluation to obtain those CME credits. Will Rodriguez will now introduce our distinguished speaker.
Thank you, Rob. Dr. Chandra is the Chief Telehealth Officer of the Center of Telehealth at the University of Mississippi. After completing medical school in India, he completed a PhD in life science in the U.S., followed by a research postdoc fellowship at Cincinnati Children's Hospital and Medical Center. This was followed by clinical training in the internal medicine and critical care, the latter from a prestigious program at the University of Pittsburgh Medical Center. While working as a tele-ICU physician, he developed a passion for telehealth as a transformative modality for delivering cost-effective healthcare. Previous to his current role, Dr. Chandra was the enterprise-wide medical director of telehealth at the largest health system in the state of New York, Norwell, where he oversaw the clinical implementation of telehealth programs in the acute and post-acute care settings, including critical care, hospitalist medicine, stroke, and skilled nursing, as well as leading the telecritical care response to COVID-19 pandemic. When not busy implementing clinical programs, he enjoys introducing telehealth to medical students, residents, and fellows for continuous growth of the field in the next generation of clinical leaders. Dr. Chandra?
Yeah, good afternoon. Sorry, I'm a little bit late because I had some trouble joining, but I'm here now. Dr. Santos, how are you?
I'm doing well. Nice to see you again. It's been a while since we last saw each other in Boston.
Yes, absolutely. Happy to be here. And with me, I have Greg Hall, who is our Director of IT and is the longest employee of the Center for Telehealth, and one of the most valuable employees of the Center for Telehealth. And so, are you ready for me to start the presentation? Okay.
Yes, sir.
I am going to try to see if I can share my screen.
That looks good, sir.
Okay. Thank you for the opportunity to talk about our journey in establishing the Center of Telehealth and Center of Excellence here at the University of Mississippi Medical Center. I just moved here 2 years ago, and it's been a great journey learning about our landscape here in Mississippi, as we are moving towards the end of the pandemic and trying to set up telehealth programs. So I have no disclosures. I'm going to tailor my talk to around 45 minutes and then leave some time for question and answers with the audience. I have no financial interest with any organization or any commercial products or services that I discuss in this program. For our agenda for our meeting today, we are going to describe our center, Telehealth Center of Excellence, its accomplishments, expectations, and actually walk you through some of the ways that you should be thinking about, if you're thinking about establishing a center for telehealth that excels in what you're trying to do. And then, of course, there are always challenges and pitfalls and barriers, and we are going to point to some of those as we have experienced in our journey here. So I know that everybody's aware of what telehealth is, but just wanted to state the definition. It's a delivery and facilitation of health and health-related services, including medical care, provider and patient education, health information services, and self-care via telecommunications and digital communication technologies. So telehealth, of course, is the umbrella definition. Telemedicine is more, although they are interchangeable, it's more, limited in scope, where it's actually more defined. It pertains to exchange of the clinical information and pertains to practice of medicine, while telehealth is a broader definition, encompasses education and other services as well. And of course, when we talk about different modalities, most of the time we are talking about audio, video, but as the audience may already know, that during the pandemic, audio and only telehealth was allowed as well. And there's a lot of attention being paid to that modality as well. It is allowed still by Medicare, but we don't know how that shapes up after the pandemic is over, although Medicare, I believe, has made it permanent that audio-only visit will be allowed for Medicare beneficiaries when they access behavioral health, mental health services. Store and forward is still upcoming modality for telehealth. A lot of different applications in dermatology, radiology, ophthalmology, where you can take images, pictures, and send to your provider. But one emerging branch, so to speak, of store and forward is the provider-to-provider consultation, where you can asynchronously send information from a PCP to a specialist, and that also comes under store and forward. In Mississippi, in a new statute that came into play July 1st, 2022, store and forward and provider-to-provider consultation is now part of broad telemedicine definition and reimbursable. Remote patient monitoring, of course, and mobile health have been there for a long time. We consider ourselves as one of the experts in RPM, and that's one of our signature programs. We're going to talk a little bit about that. So, of course, everyone knows about the benefits. We have seen that during the pandemic, but when someone asks me, and we think about telehealth projects, when we are implementing, we talk about 4 buckets. Before, what it does for the patient, how does it improve their access for services? How does it impact the providers? Do they feel that these visits are clinically appropriate? Is it seamless for them? Or are they spending too much time with the technology? It's not working for them. So patient and provider satisfaction are very important, as well as clinical outcomes and of course impact on healthcare spending at a macro level. But then what in terms of reimbursement and reimbursement for the health system, it's very important as well. So I'm going to ask Greg, who's been here 22 years, to talk about the journey, how we started, what programs we established along the way. So Greg, I'll change the slide when you let me know.
Thanks, Dr. Chandra. So just to give you a brief introduction of myself, I'm the Director of IT for the Center for Health. Like Dr. Chandra said, I've been here for 22 years and was part of the original implementation of our first audiovisual telehealth program, which we'll talk about in a second. So UMC started as a whole in telehealth with store and forward of EKGs. So pediatric and adult cardiology started in the 90s. But then in 2003, we actually started working on the program in 1999. But the Telemedicine program, which is one of the, if not the cornerstone program that got us started in telehealth at UMC, actually went live October 1st, 2003. You heard me reference 1999. That is the first email that went out to the state board of medical licensure to get their approval for the idea. It took us 4 years to get that approval. But once we did, that program really did take off and is still very successful today. And really is one of the key fundamentals of starting a telehealth program is you've got to have that cornerstone, that first program that is your successful program that leads to other programs throughout your institution. So you'll see a 5-year gap there. Telepsychiatry began in 2008. That was a very unique program around trying to prevent moving of mental health patients that were institutionalized in the state, but then actually also introducing patients when they were going to be discharged back home to their local community mental health center. So instead of having to transfer that patient back and forth when they weren't quite ready to be discharged, but we're getting close, they started doing telehealth consults between the two centers just to introduce the patient to the staff that worked at the local community mental health center. In 2011, first full-time staff was assigned. That was me. Kind of weird that it was an IT resource that was assigned, but that was the need at the time. And then in 2013, the Center of Telehealth at UMC was formed. That was a lot of work done by Dr. Robert Galley and Dr. Christy Henderson at the time to actually establish a center focused on just telehealth at UMC. Its goal really is to make sure that we are basically doing the same across the institution, no matter which department is doing telehealth, and then to lead the institution in a single direction when it came to telehealth. We didn't want fragmented care happening and different platforms being utilized just because there wasn't a centralized institution focused on telehealth at UMC. So that's why the center was formed. Go ahead, Dr. Chandra. So in 2017, we were awarded the Center of Excellence in Telehealth by HRSA. That was a lot of the hard work that had been done along the way led to that award, and basically allows us to do research for telehealth and be able to show to the federal government what doesn't work in telehealth. And that really has really put a focus on our telehealth research endeavors and really spearheaded that our ability to do that research in telehealth for not only us, but the entirety of the United States. In 2020, a little thing called, a pandemic happened, as everyone knows. And it's interesting to see that is what the impetus was of actually getting our video platform embedded in our EMR. So we went 17 years with the video being outside of the EMR. If you're curious, we actually went live on Epic in 2014. So 6 years within the EMR without having video enabled. But we really were only doing basic, I won't say basic, but we were only doing clinic to hospital type telehealth endeavors at that point. All of a sudden in 2020, we needed to switch ambulatory to telehealth as well. And that really was the impetus to get that video embedded within Epic. In 2021, the FCC funded our RPM program. So that, again, that enabled us to expand that program out more. That's typically what we do with our grant funding is we expand programs, especially ones that aren't centered around research. This one happened to be for connectivity. So that enabled us to put more and more people on our RPM platform that insurance couldn't necessarily pay for. And then again, in 2021, we were renewed by HRSA for the Center of Excellence again in telehealth. And that's what still love that funding to be able to push research out for telehealth to the general population. Go ahead, Dr. Chandra. So just to give you a snapshot of where what kind of services that we do and where they are served. So it basically any kind of setting that we can get telehealth in at this moment, we're trying to push telehealth into those locations. You'll see schools, community mental health centers, community hospitals and clinics. corporations, FQHCs, even patients' homes at this point. Again, the pandemic really did enable that basic us being able to get paid for services in patients' homes. So we have expanded what we were doing in patients' homes. All the adult services that we're doing are dementia and Alzheimer's, cardiology, corporate health, which is centered around providing urgent care to different corporations throughout the state so that when their employees get sick, instead of them having to go to a clinic, in some cases they're out in the middle of nowhere and they don't have a clinic, they can see our urgent care providers instead through telehealth. We do dermatology, emergency medicine, radiology, mental health services, and infectious diseases that really is geared towards HIV. And then, of course, we talked briefly about the pandemic. This is, I think everybody has this slide at this point. It's the exponential growth that happened between 2019 and 2020. Like I said, in 2019, we were still focused on just clinic to clinic, clinic to hospital type telehealth visits. And all of a sudden in 2020, we were doing at-home patient care. And that is what led to that dramatic growth. If you're interested about where we leveled off, we're leveling off about 80,000 telehealth visits a year at this point. So yes, we took a dip once everybody came out to clinic, but we're still seeing a lot higher growth than we ever had before the pandemic happened. With that, I'm turning it back over to Dr. Chandra.
Thank you, Greg. So I'm going to talk a little bit more about our clinical programs and how we think about clinical programs. So what is our role as a National Center of Excellence? I divided into 4 buckets. Of course, the biggest piece of that is improving access to healthcare services for our population in the state and outside via telehealth. That's one of our biggest goals. And of course, trying to come up with innovative programs, trying to see whether they work, what are the barriers and challenges, measuring their effectiveness. That's all part of our goals as a Center of Excellence as well. And then another big part is to assess, the impact on healthcare spending, whether by doing cost-effective, cost-benefit, different kind of analysis at the macro level, at the micro level, what kind of services are reimbursable, not reimbursable, cost to the patients, cost to the health system. I think those are very important. And then, of course, we want to collaborate with other entities around the country and share best practices for setting up different programs. So when we think about our telehealth projects, there are a few things that we have developed a framework that we put and look at our telehealth projects, whether they're meeting some of these things that I'm going to talk about. And one of the things is that, and I think Greg mentioned to that, that it should not lead to fragmentation of care. There should not be silos. It should mesh very well with the existing care delivery. Some cases there would be hybrid delivery models that we should develop. But even if we are developing an independent program, then there should be back and forth communication with different kind of providers so people are informed. So that's very, very important that there should not be fragmentation of care. And we should actually do a need assessment. You really need a telehealth program. What are your goals? What are your objectives? What are you trying to fulfill? So really doing a need assessment and trying to figure out where the gaps are and whether you can really bridge those gaps by telehealth is very, very important. So of course, telehealth programs should create and demonstrate value for multiple stakeholders. We have developed a kind of an evaluation for different domains during implementation, during the pre-implementation phase, during the monitoring phase as well. And so it should basically demonstrate value for multiple stakeholders, whether they're payers, patients, providers, health systems, policymakers. Should transform care across the care continuum, and of course, reduce disparities in access to healthcare. There's a lot of growing concern around digital divide being exacerbated by telehealth, and we should keep that in mind when we are trying to set up telehealth programs. What I mean by care continuum, what I mean by that is that telehealth programs should serve all age groups, in all settings, and many of that has been is enabled by the pandemic, and the loosening of the regulations. For example, providing services to patients at home. So telehealth should provide, services to all settings and different kind of care, whether it's preventative or medical incidents. And this is a busy slide, but this is how we think about what age group the patient belongs to, whether it's the elderly, adolescents, child, adult, and where do they receive care. And I'll just take one example. Your child can receive care at home, they can receive care at school, at primary care physician's office, and the hospital. What are the current programs, where they go, what are the services that are available there, where the gaps are. For example, for a primary care physician office, they may have trouble getting referrals for specialty consults. So that's a big issue in rural Mississippi. So thinking about store and forward, provider to provider consultations, can we provide that to the primary care physicians? Or echo projects, can we help, and you're already aware of that, can we educate the primary care physicians to be educated and manage some of these more complex patients? So understanding what the population that you're serving, where they are currently getting their care, and what are the gaps and how you're trying to bridge those gaps is very important before you go ahead and implement different programs. And I'm just giving a few examples. For example, if you are targeting, pregnant patients, then the different kind of programs that exist. I'm going to talk about a particular favorite of mine is hypertension RPM program for pregnant females who have either first time showing hypertension, or they have a history of chronic hypertension. And we have set up a remote patient monitoring program to actually prevent the patients from complications like preeclampsia, very popular. We are looking at the data, but it's a great program that we just set up last year. The targeting pediatric health. I mean, you can, as I said, you can provide services at home, urgent care, behavioral health, remote patient monitoring, at school, specialty consultation, inpatient consultations, so different kind of patient population, where they get this care, and then trying to understand where your gaps are, what are you trying to achieve, and tailoring and implementing programs that are tailored to your specific needs. So a big example of for the pediatric population is our school-based telehealth program. We also received a grant funding from Mississippi Department of Health. We are setting up one of the largest school-based projects in the country. It is going to be implemented in almost 600 plus schools. We have already gone live in 176 schools within a matter of 3 months. We started the project implementation August 1st, and we have implemented in 170 schools. So, and again, it should provide continuity of care. Parents are provided a summary. Primary care physicians are provided a summary, and a school nurse is the liaison between the telehealth provider and the parents. As I mentioned, live at 170 schools, 78,000 students can access our services right now. This is just showing data that the utilization is just picking up. We just implemented, and of course, we are now focused on making everyone aware of our program so that the utilization goes up. Adult, again, wherever you are, just giving you think about where your care is being provided, where the gaps are, what are different kind of telehealth programs are available, and how those programs can bridge gaps. Just to mention a few programs here, tele-urgent care program. We have made this available 24/7, 365 days a year. Our nurse practitioners are available for population throughout the state. Telemental health, of course, there's so much shortage of mental health providers, big shortage. We have a team here of who can do medical management, as well as we have LPCs, counselors, to do both counseling and management of patients seeking behavioral health. Teleemergency program, Greg just mentioned, it is now our ED providers are providing consultations to 21 critical access emergency departments throughout the state. It has not only shown benefit for the patients who you can avoid unnecessary transfers out of their community, but it has shown to the data that has shown that it contributes to financial viability of these critical access hospitals, because you can retain the patients in your own hospitals without having them transferred. Remote patient monitoring, of course, is a signature program of ours. We have so what remote patient monitoring means is that we provide devices to patients in their home, and these devices can measure, blood pressure, blood glucose levels, can also measure weight, pulse oximetry readings. So variety of biometric data is collected through the devices. It's captured, by the devices. Then we provide the patient with tablets. From the tablets, it comes to us in the telehealth center. We have not only nurses who monitor the data, but we also have our clinical pharmacists, and we have algorithms that are built around evidence-based best practices for that particular chronic disease, for example, CHF, for heart failure, for hypertension, diabetes, and our pharmacists can look at the data. When their data is out of range, they can talk to the patient, and based on those algorithms can do direct medication changes as needed. And the clinical pharmacist is backed up by endocrinologists, a cardiologist as well. So this is just showing the schematic of the data coming to us. In addition, because we give the patient tablets, and we are able to provide daily education sessions to the patients, because at the end of the day, we are trying to empower them by educating them about their disease state, when itself has shown to impact the clinical outcomes for the patients. So we have a team of nurses, as I said, and a clinical pharmacist that meet regularly, look at the data, make medication changes, and then give a summary back to the primary care provider. So the primary care provider does not have to deal with making those medication changes. And there are a lot of different programs that come under our RPM umbrella, and there are some other programs that we are actually are in the process of implementing, like COPD and for asthma. And this is just showing very robust data that we have for systolic blood pressure and for these patients, and as well as hemoglobin A1C on the right-hand side. And we have Dr. Clark, who is our medical director for the RPM program. He just published some good studies for hypertension, and we are just submitting our publication for blood glucose. A great patient feedback for our program. Our nurses monitor the patient, discuss the, if they see the patient has data that is out of range, they call the patient first. So that communication ensures that there's more adherence by the patients for the program. There's more adherence and compliance with their medication regimen, and that all leads to good clinical outcomes. So those are just our I would say regular telehealth programs that are very well established. But because we are a center of excellence, every year we come up with new projects after looking at where the need may be, and trying to come up with some new projects that can bridge those gaps. And then, if we see good outcomes, then our goal is to publish, to let other people know of what we have done. So I'm just showing you a snapshot of some of the programs that we are, in addition to our telehealth, clinical telehealth programs that exist, we come up with different ideas every year. So for this year, we are promoting RPM at FQSCs. So we are going outside our backyard. We are getting patients from FQSCs and demonstrating the value of RPM for more rural, diverse population. And with that comes challenges of how to integrate data from different FQSCs. And so data integration from FQSCs is a very important part of that. So we anticipated that, okay, we are trying to set up what may be the challenges, how can we overcome that? Data is a big part of that. So Greg and his team are working simultaneously on a different project to bring data so that we can take on patients from different FQSCs and even small primary care physician offices throughout the state, and expand the reach for the RPM program throughout the state. We are also, moving forward with a very ambitious program. Everyone has heard of digital divide. There's growing concern that patients who are more digitally savvy, who have access to connectivity, may have more access to telehealth programs, and digital equity, digital divide is a kind of a buzzword now. But and so we are actually trying to develop our own telehealth RPM platform that addresses some of these concerns, and designing a platform that is tailored to different patient population, vulnerable patient population, and with different needs. So that's another project that we are working on. And then we are trying to develop an outreach program for helping Oklahoma State University develop their own RPM program. I already talked to you about our school-based program, specialty care to rural hospitals. We are trying to bring a inpatient neurology consultation, tele-ICU. Everybody is quite familiar about, but there's not much data about other specialties, and we are trying to do inpatient consultations and compare and measure and compare its effectiveness to bedside rounding. Digital disparities, bridging this digital disparities, we're going to pick up patients who don't have access to digital devices, connectivity, and give them those devices and see if they can then utilize telehealth services that reduces their visits to the ED and hospitalization, and have better outcomes for that patient population. Again, a big impetus on behavioral health workforce development, and different other projects. I'm not going to go into the details, but just this is a very snapshot of our comprehensive 25 projects that we are trying to implement in the next 1 or 2 years. So now moving to putting all together, I was asked to talk a little bit about logistics, and I am going to give you some pointers from our experience here as to how you should be thinking about. And I think I would start with this slide, which I love. And this is from Impact Advisors, and I still look at it for my, to see where we are. And these are different stages of maturity for telehealth programs. Stage 1 and stage 2, where most of the programs are still existing, are basically programs that they don't have a central telehealth program, they don't have a central infrastructure, they are more independent department, service line based programs that are independently administered and based and are not kind of a central infrastructure that are behind these projects and programs. And most of the existing telehealth programs around the country still fall under stage 1 and stage 2. Stage 3 is there is a central organization structure, and they have multiple service line, multiple projects that are aligned with the organizational strategies and goals. But stage 4 and 5 are more nimble, more have a portfolio of different programs that they adjust based on market needs, based on, and they go outside their backyard, and then they can go outside the state, they can go in other states. So those are really self-sustainable models that look at revenue streams and try to have a bigger picture in mind to not only cater to their own population, but go beyond that. And so I would really impress upon anyone who wants to establish a telehealth center. I would ask them to say, ask yourself, where are you in this maturity stage? Which stage are you in this? And then where do you want to go? What are your goals in the next immediate future or long-term goal? And then plan accordingly. What do you need to get from one particular stage to the next particular stage? Do you have the resources for that? Is that a reasonable goal for you? And so it's very important to know where you are and where you want to go. This is actually a slide that I borrowed from a great publication. And I would again, if someone is wanting to, in an academic medical center is looking to build a telehealth, I would ask them to look into this publication by Managed Health and UMMC, and it's called Sustaining Telehealth Success, Integration Imperatives and Best Practices for Advancing Telehealth in Academic Health System. This is an executive summary, but there's a longer version of that is also available. But what it tells you is, again, it actually divides clinical strategies into 4 buckets. And it's nothing different from what I just previously mentioned, but what are you trying to achieve? Are you trying to develop strategies that optimize care in the hospital setting or in the ambulatory setting? If the ambulatory setting is distribute access to an integration of care, managing population health, are you trying to do RPM, for example, or improve community and public health status? For example, our school-based telehealth project would fall under improving the community and public health status. So think about the clinical strategy that you are trying to pursue using telehealth, and then what are the different program portfolios? And I talked about, in patient setting, you can have different specialty consultations, ambulatory, particular service lines, and so forth. So identify priority clinical strategies, then develop telehealth program portfolios so that then you can say, okay, this is my portfolio, that is my eventual portfolio in 3-4 years. This is how I'm going to start, and kind of lay out your plan. And to be able to do that, you really need to integrate telehealth throughout the organization. And you should have discussions with leaders, and it should be part of different department and their clinical strategies. You should be working very closely with the revenue cycle folks, with the CFOs, with operational people, which comes in legal, compliance, contractual, of course, information technology, academic and community missions. So you should be working with all these offices within your organization and work very closely so they understand what you're trying to do and they can support you. And a large part of our job is, for example, Greg's job is to meet with our DIS, Office of Information Systems, and their leadership, apprise them of our projects and keep them engaged. And I do it with the department leaders at my level. So again, organizational integration, I think that is something, I'm not going to go into too much detail, but that just represents the different pillars of your organization and how you should be engaging with different pillars. Once you have done that, simultaneously, you have to build your own team. And this is our team structure here at the Center for Telehealth. And you will see that my pillars actually kind of mirrors at the organizational level strategy that I just talked about. So we have a administrator, and he is in charge of budget and finance, and he's charge of working with financial integration. We have director of IT. He is working with IT integration. We have clinical program strategy. They're working with department leaders. Director of operations, working with operational integration. And then we have a research administrator. They are working with furthering our research projects and making sure that all the timelines are met. So this is what we have understood that our needs are, and we have, kind of placed these pillars with a team leader that oversees that part of the team structure. And I think it's very important to have a good team, because you have to tie up all these things before you can have a successful program. So putting it all together, think about creating the right clinical team. Are you going to utilize in-house team? Do you have the bandwidth? If you don't have the bandwidth, you can go outside. There is no harm in developing collaboration. There's some pros and cons to both. This is just showing a tele-ICU collaboration that in my previous job, I did it from providers in the Northwest. So we ran out of our bandwidth. So we brought in providers at a different location. So choose different programs. Then again, you have to put the right team. And once you have that, you can have different programs. So for example, you have urgent care and behavioral health. You can mix those two teams, and you can create a direct-to-consumer program, urgent care program for state health plan members. You can use the same team for school-based telehealth program. So this is how we think about our different teams, put them together, and then see cross-functioning, what can they do together to build some programs. I'm going to hand it back to Greg to talk a little bit about how to think about EMRs and technology side. Greg?
Thanks, Dr. Chandra. So as Dr. Chandra was speaking, one of the challenges is the data and where you're going to be able to receive that data, and then where to put the data ultimately, especially if you're doing care outside of your own health system, which is one of the ways that we initially took off. And so basically your thought pattern around that really needs to be have a single source. It's easy to say, it's hard to get to, but you really do need to be able to provide that healthcare data to your care team, so that at the time of the telehealth visit, they actually have the data that they need to be able to perform that visit. I'll be frank, we were very, I won't say unaware, but very remorseful in not having that initially in our telemedicine program. That took several years to develop, not to mention 2003. Most everybody was still on paper. So what we ended up doing was providing each of those emergency medicine programs out access to our EMR. And that was a easy way to get all that data into one place, so that our physicians at the time of consult knew what was going on, and had all the data behind the consult. But it's just something to keep in mind going forward, that as you're developing telehealth programs, just realize you're going to have a lot of data paths that you got to bring together. Go ahead, Dr. Chandra. So one of the things that we're working on now that Dr. Chandra referenced is we are partnering with the Mississippi Hospital Association on creating a workflow that enables us not to have to do all the work, which is great. The Hospital Association has taken upon themselves to create a statewide HAE in the state of Mississippi. With that comes the ability to do referrals. So what we're working with them to establish is a true referral network. We will be the first to be able to receive referrals through that network. But we're also working with the hospital association to get non-hospitals onto the HIE as well. So places like FQHCs and local small clinics, enabling them through some of our HRSA money to join the network, so that when they send us referrals, we actually have all the information. Basically what happens in a remote patient monitoring referral, for instance, is that it gets placed onto our patient panel at that point. And so if that patient ends back up at that local FQHC that referred them to us, we actually get the updated information in real time. So as soon as that record is closed at that FQHC, it sends that over to us because we're on their patient, their provider list at that point. So it's going to be a very nice system. We're still working out how that's going to happen and all the pieces to make that happen. But at the end of the day, that is the ultimate goal of that collaboration. Go ahead, Dr. Chandra. And then finally, what the ultimate goal and strategy is you need to have some way to actually measure what you're doing. And the only way to be able to do that is to have the data there to be able to provide that data to the research team so that they can come up with that actual care cost. You need to be able to demonstrate your value and influence your growth in policies supporting telehealth. And then, of course, the large amount of data have to be stored somewhere, and that's crucial. So what we're actually doing at UMC now is creating a nationwide telehealth database. And it's one of the initiatives that Dr. Richard Summers had before he left, was to create a database and a dictionary for telehealth terms. So that when you talk about originating site and distance from that saved, you actually have standard terms across the industry that will be able to go across the continuity of care, so that everybody's talking the same terms when we're actually providing data back to each other. So go ahead, Dr. Chandra. And back over to you, Dr. Chandra.
Thank you. And most clinical leaders, actually, I will admit I'm clueless about budget, but thankfully I have a budget person here with me. But when we look at our budget, most of the expenses come from are incurred by the staffing. So always have to think about your budget, always think about projects, what kind of staffing is required, what is the impact on the budget. But Matt, you have to always think about staffing. That's not a surprise there. Most of our revenue are still coming out from contractual agreements with different entities that we provide services to. And then we are also, seeing more reimbursement coming for our project, but right now it is divided 80-20 based on contractual agreements and what is coming through reimbursement. Barriers and challenges, I'm going to spend a few seconds on that, minutes on that, and then, we can have we can take some questions from the audience. Yes, there are a lot of barriers that are still existing. Our biggest challenge has always been reimbursement. And as we know that reimbursement is a very dynamic stage right now. The PHE is going to end sometime next year, but we don't know what changes are going to be permanent and what not, because if not, then, some of the services that are available at home would probably go away. For example, audio only is not available, is not reimbursed by Mississippi Medicaid. It is in other states, but Mississippi Medicaid had stopped reimbursing for audio only visits. That had a significant impact on audio only visits that they're being done by specialists at Children's Hospital. So reimbursement landscape is still, it's better, it's improved, but we are still awaiting the final word on that. Interoperability with different EHR, EMRs is still an ongoing issue. There are now integration engines that can integrate, but it costs money, it costs time that has to be taken into consideration when thinking about different projects. Where are your patients? Are they outside your EMR? Then how are you going to integrate data and perform audio video visits? Legal, of course, credentialing, licensing, malpractice liability, and even service agreements all take a long time. Build templates for your agreements, ask other entities to provide agreement templates that you can use to shorten the time. Use credentialing by proxy. So there are ways to reduce the time to get all those things done, but always keep that in mind. Still a big challenge. Provider adoption, patient preferences and adoption and buy-in. They still remain challenges with that. Providers sometimes feel that they're not getting enough clinical information. The technology is not working seamlessly for them. The reimbursement is not up to the mark. Patients don't feel like they are having a good service or answers from help desk if they run into technical problems. So all those are ongoing issues that make it challenging, that are challenging. But I think at the end of the day, if done with due diligence, it gives a lot of satisfaction. So I'm going to actually stop there. I want to just mention, what we speak about here in these presentations. It's, we take credit for all the hard work that is done by other team members. So I just wanted to acknowledge all the effort that goes into building a project, and happy to take any questions.
Well, Greg and Dr. Chandra, Dr. Chandra, thank you very much for the wonderful presentation. I think your presentation is very encompassing of all the things that I already, planning to ask, regarding health information exchange and, increasing access and, the measurements of quality and, metrics, on how we could implement a successful telemedicine. But what, I think would like to ask you is, and I think this is the same problem that is encountered even in your other COE, the other, Center of Excellence in MUSC. And you alluded this already that, you have to think outside of the box to the point of hiring your own, telehealth providers. And they have the same problem though in MUSC as well on how to really integrate telemedicine to the academic medical center, because I think you showed a nice graph of 950 times increase in telemedicine activities. But if we will look on our current activity right now in 2022, most of the academic medical center dropped to 20% or even less. How could we sustain telemedicine activity, and how could we convince our colleagues, our providers to adopt telemedicine?
Yeah. There's multiple strategies that you can do, and it depends upon whom you're talking to. If you're talking to business people in different departments, they are looking at financials. If you're looking at, so what we came, and of course, there's no payment parity. So for some of those visits, they're now saying, well, the inpatient, in-person visits are reimbursed at a different level. Why would we do that? And that's a very tough argument to counter. But something that we came up with, and we are now working with DBAs and providers, and they have become very excited. I just gave a presentation to the ambulatory operations at the Children's Hospital, and what I told them that, what about e-consults, provider-to-provider consults that can add revenue, because you don't have to dedicate some time from your clinics for these audio-video visits, and you can get reimbursed for these provider-to-provider consultations. And then everybody became excited because they will bring revenue. The providers feel they can do it on their sweet time. They don't have to dedicate and carve out time for telehealth during their busy schedule. And everyone wants to provide access to healthcare for patients. So there are ways to do it, and we are now focusing in the ambulatory side by looking very closely at provider-to-provider asynchronous consultations. We are looking at predictive analysis modeling that can be done in Epic that actually shows what this patient is going to come for the in-person visit or not. And if there's a high probability that the patient will not come based on their history and some features and characteristics, then we are trying to pivot and call the patient beforehand and say, would you like to do a telehealth visit instead? With the idea that if the no-show rate goes down, the cancellations goes down, then it is a win-win for patients, for providers, as well as the business administrators. So you have to work closely with them, trying to find ways to sustain telehealth. It's challenging, but can be done. And at the same time, an academic medical center always focus on the next generation of providers. So educate your nurses, your physicians, allied professionals, so that you are investing long-term and not just short-term.
I agree. That's why we have our student interest group here. Roald is a second-year medical student, and he's here already, being immersed in telemedicine. Will, do you have any question for Dr. Chandra?
No,
Greg?
good seeing you again, Dr. Chandra. Thank you very much for
Perfect.
taking time.
Thank you.
Any question from the crowd?
Yes, I had a question on the remote patient monitoring. From what I understood from your presentation, was this remote patient monitoring, is it a 24/7 program, or and is it involves more of nurse practitioners and clinical pharmacists, and where does the role of physicians come in RPMs?
So very good question. So first of all, it's not a 24/7 program, but you can build it. But most of we are having patients who are not very, high risk. This is for patients who are stable at home, and we are doing management of their chronic diseases. So it's a 8 to 5 program, and we have the nurses in-house. So the monitoring data is the data that comes in is monitored by our nurses, our clinical pharmacists, then do the medical management. There are 2 ways that you can engage physicians. One is the primary care physicians. You can take the nursing data, hand it over to the primary care physicians to do the medical management, and then you can bypass the clinical pharmacist. And most places have that paradigm. But we feel that we are trying to offload the primary care physician anyway, so it's better for us to take over the medication management. So we have a cardiologist and an endocrinologist. They work on different algorithms, and they provide the clinical pharmacist with the algorithm. The clinical pharmacists do the medication management. When there is a change that they do, they send a report back to the primary care physician. That were the reasons, that this is what the data showed, and based on the algorithm, they made these changes. And of course, when they're complex patients requiring multiple medications, then they discuss the case with the cardiologist and the endocrinologist before making those changes.
Thank you.
Thank you, Dr. George, for the excellent question. Dr. George is one of our nephrologists here, Dr. Chandra. I have a question, though. You know how it is in the United States, the delivery of healthcare is very complex. They are FUQHC, your primary care physician, the academic medical center, different hospitals, to the point that I think our healthcare system is a little bit kind of fragmented. And probably Dr. Chandra could give us ways on how could we potentially, integrate all this, provider of healthcare without breaking down the silo, without essentially removing the control, because our problem, I think, is some of the hospital and some of primary care physicians felt threatened that, you're going into their realm up to the point that you're poaching their patient. So how do you address that issue, Dr. Chandra?
Yeah, so it's a very good question. Patient-centered medical home is a big concept in the ambulatory side. And when and I'll give you an example, when we were, coming up with our, telehealth, school-based telehealth program, there was a lot of questions and concerns raised by primary care physicians and family physicians that, you are making decisions for their patients without their knowledge. So we actually spent a lot of time giving statewide webinars, which we brought, members from the association. It was free for anybody to join, and we provided them with information, answered their question. But then what Greg has done is every time my nurse practitioner is seeing a patient and the patient family says, yes, I would like to send a summary of this visit to my primary care physician, a summary is electronically sent. We have a registry in Epic. of all the primary care physicians in the state, majority of them. And if they're not on there, we can add them. And we then, once the patient's family members give us permission, we send a summary so that they are in the know of what is done. Also, we didn't encroach. We said referrals to specialists, although we have specialists here, but we didn't make that part of our program. We said, keep the control with the primary care physician. It's their job. They know the patients best. So the referral to specialists is not being done by us. We ask them to go to the primary care physicians to ensure that they follow up with primary care physicians, and they are the ones who are referring to the specialist. Also, for remote patient monitoring program, we always ask the patients to go and visit their primary care physicians every 6 months. So actually, primary care physicians are seeing some patients that they have never seen because we are asking and reminding them to go and see their primary care physicians. And that builds those relationships, allies, fears, and doubts. And it takes time, but you can come up with ways that everybody is involved, is in the at least in the know of what's going on.
Well, any other question?
I have
a
Dr.
quick
George?
question.
Oh, go for it.
Yeah, so,
Dr. Chandra.
okay,
Oh,
go ahead.
sorry.
Go ahead, sir.
Okay. Dr. Chandra, are you involved or are you aware of any advocacy being done to have the CMS and the insurers continue the
Absolutely. I mean, I think there are a lot of national bodies that work with us, and we send them letters and request them letters that goes to the policymakers in Congress. One of them is CTEL. Of course, American Telemedicine Association has come out with a lot of asked for a lot of letters from different associations, and we have provided letters of support for bills that would continue to support telemedicine.
Yeah, and to add, Dr. Chandra, I'm part of the UMMC. We're actually advising UMMC and AMA. They have a lot of PACs, political advocacy group that is really advocating for telemedicine. But that's a great question, Dr. Chemitiganti. Any other question, Roald? Do you have any question for Dr. Chandra?
I just wanted to thank you all for offering us time. I think that was a great presentation, especially for us here for the telemedicine program at TTUHC. I'm only a second-year medical student, so I may not have a lot of skin in the game. I'm not a healthcare professional yet, but I just wanted to ask a quick question. One of the moves that Dr. Santos and I initiated was to create a telemedicine interest group to foster interest in telemedicine with medical students. I wanted to know how can, what are some other things, or how can students get more involved with telemedicine and also kind of support the maturity of a telemedicine program like here at TTUHC?
So I would, this is what we are doing here. I think for different M1, M2, M3, M4, we have integrated telehealth in their curriculum. For M1, we are giving them lectures. I'm giving a lecture in January, but I'm going to take my mobile card and my devices, make them aware of them, then for the more senior M3 and M4s, we are providing 2 and 4 weeks electives for telehealth, where they can actually work with providers in their offices or in the emergency department or with our urgent care providers, and actually partake in those visits to get ideas on how to perform telehealth visits and actually take patient history and do examination. So integrate telehealth into your curriculum.
All right, we are beyond the time, and thank you very much for your generous, presentation and being here, Dr. Chandra. Just letting you know as well that Texas Tech is actually creating an Institute of Telemedicine. We're actually in the process of doing our executive director search right now. Will is the head of that search. And what do you think you should give us, 3 or 4 advice, on the creation of this Institute of Telemedicine?
So team, the biggest thing is you have to have the right team and the right support from the leadership. And if you're looking for, a person to lead the institute, that look for a person who has real passion for telehealth.
All right, then I would like to, invite ourselves as well. I knew you guys are doing a telemedicine data warehouse. I'm hoping this could be a nationwide warehouse. I
Oh,
think
it is
I
a
proposed this.
nationwide, we are asking for people, entities from the entire country to join it. So we would be happy for you to join us.
That will be wonderful. Thank you for the invitation.
Yeah.
Anyways, for our attendees, don't forget to sign or click your evaluation using our QR code. And I would like to present Greg and Dr. Chandra, our challenge coin. There we go. We will be sending you our challenge coin, Dr. Chandra and Greg. Thank you very much again for your for pioneering telemedicine and being a champion of telemedicine. I just like to invite everyone that Dr. Todd Bento will be presenting a telemedicine in HIV and infectious disease cases next month in celebration of HIV and AIDS Awareness Month. So thank you again, Dr. Chandra and Greg. I really appreciate it. And UMMC is very fortunate to have you in their team.
Thank you.